Hello, and welcome to today's McMaster University Continuing Education Caregiving Essentials webinar, PTSD and Caregiving, How Memory Sabotages Us. I'd first like to begin by acknowledging the land on which we reside. McMaster University recognizes and acknowledges that it's located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. My name is Erin, and I'll be your host on behalf of Continuing Education. Today, I'm joined by our facilitators, Donna Thompson and Patrick McGraw. Without further ado, I'd like to introduce to you Donna. Donna Thompson is a co-author of The Unexpected Journey of Caring and the author of The Four Walls of My Freedom. Donna is a patient and family advisor on health research and policy, and she teaches family caregivers in Canada how to advocate for care in hospitals and in the community. She blogs regularly at the Caregiver's Living Room. Donna is a facilitator of Caregiving Essentials and Infection Prevention and Control for Caregivers and Families, our free online courses for family caregivers. And now I'd like to introduce to you Patrick. Dr. Patrick McGraw is a clinical psychologist, scientist, senior health administrator, and social entrepreneur. He currently is Emeritus Professor of Psychiatry at Dalhousie University and scientist at the IWK Health Centre in Halifax, Nova Scotia, board chair of the not-for-profit Strongest Families Institute, and a clinical psychologist at the Centre for Mental and Psychological Health in Ottawa. Dr. McGraw is the recipient of the Order of Canada for his research. And now, Donna, I'll hand things over to you.
Thank you so much, Erin. I just couldn't be more delighted to be here today with you, Pat. We are old friends, we're colleagues on this very, very important and interesting research project, which you're going to tell us about. And I think, I just want to begin by saying that we're very sorry we've had technical problems today, and many people were not able to access the link live today, but we are recording our session as originally planned. We will be sending this link out to everyone who registered, and we will be identifying a date and a time which we hope you'll be able to join us for a live Q&A based on our presentation today. So Pat, welcome. And can you begin to tell us and walk us through the research project that you and I worked on together called Beyond Trauma, Life Beyond Trauma?
Right. Well, as you remember, it started when we had another meeting about another project that was related, one that we're doing at the center that I work on. And I had been rejected by a grant for CIHR, something that happens frequently to everybody who applies to CIHR. And it was a PTSD grant. And you said, well, why don't you do a PTSD study on us? And I said, what? You said something like, well, think about it, Pat. Our children are born, probably they're going to be gone to the neonatal intensive care unit. Probably there'll be 3 or 4 issues that are serious because other, and then they make it through. They get to they come home with us, and maybe they have an aspiration or a sepsis or some other problem, and they're back in the intensive care unit. And this is what our life is about, that they have various different problems over the course of their lives, and they may be in and out of hospital dozens of times, and there may be other issues that we face with them on a day-to-day basis that are traumatic. And I was a bit gobsmacked because I didn't realize that indeed parents of children who are neurodiverse have a very high rate of trauma, and consequently are likely to have a high rate of PTSD. And so that's when we started talking about the study, and we were very lucky to be able to nestle it into our work with Child Bright, which is a CIHR funded network, and we started working on this topic. And we basically began two things. One is to develop the intervention using partners, parents as partners, and a very active parent group that helped guide us. And also we did a survey. So we did a large survey and a small randomized trial. Maybe go to the next
Before-
slide. Oh, sorry,
And
go ahead.
no, I just wanted to, we switch slides and move to the next slide. I also just wanted to mention for listeners who may not be parents of children with disabilities, we're going to be, looking at what we did for that population, but also reflecting on trauma in caregiving generally. And, anyone listening and watching today or later, I encourage you to, as you're learning about the nature of trauma from Pat, and what we did in this study, thinking it's an opportunity, I think, for listeners to reflect on the really horrendously frightful sometimes experiences that you may have had, and think about what this information means to you. So it's not only for parents of children with disabilities. I just wanted to mention that.
So absolutely, and so that the trauma comes from the Greek word meaning a wound, and it's really of course there are physical trauma, but the psychological traumas really have to be understood as wounds as well. In the DSM-5, that's the manual for the Diagnostic and Statistical Manual of the American Psychiatric Association, and for other ones such as the ICD-10. Exposure to an actual or threatened death or serious injury or sexual violence in one or more of the following ways. You can either directly experience it, or you can witness it, or you can learn about it in a close friend. So listening to the radio isn't a trauma, but learning about your child or your spouse or your mother, in a near-death experience is. And experiencing repeated or extreme exposure to aversive details of the traumatic event. So that's what the DSM-5 says about it. And then if you can go to the next slide. The thing is that what we know is that from many different studies, including the one we did, we know that there is a cumulative effect, and people who have one trauma are likely to have multiple traumas. Now, some people end up in my clinic with one trauma, but that's very rare. Most people who develop PTSD have experienced multiple traumas. And here's an example of a lifeline, which is taken from our the specific form of intervention that we used, and which they develop a lifeline, but almost all clinicians will develop a list of traumas with the client to figure out what they've experienced. So some of these we call them stones and flowers. The flowers are the positive things. So don't think that we're thinking that marriage is necessarily a trauma. These stones are the difficult things. And then there's some things that are just candles. Those are notable events that occurred. So we try and help people get an idea of what it is that they've experienced. Next slide. So one of the things that we did, because it was quite clear to us in our discussions with parents that there was not the traditional way of measuring trauma, didn't pick out many of the issues that parents experience. What we did was we developed a parenting trauma checklist, and this is a supplement that we used to the regular life events checklist for PTSD. And what you can see is that there's most parents have experienced a medical emergency. Many have seen their children undergoing medical procedures. They witness life-threatening situations. And then a small percentage of parents have experienced the death of their child. So these are the types of things that we find are the traumas that parents of children with neurodevelopmental problems experience. Now, if you're in a different situation, different types of caregivers may experience other types of traumas. The thing is that I think it's important for us to recognize that different groups of people will experience, are likely to experience different types of traumas. So if you're in a war, then you're likely to experience one type of trauma. But if you're a parent, you're experiencing another one. And a caregiver in another circumstance will experience a different type of trauma. All of these traumas function in the same way in terms of development of PTSD. Next slide, please. So in terms of the general traumatic events, they were also very common. So that many of our families, even though we didn't select them for having traffic accidents, they had traffic accidents. Many of them had unwanted or uncomfortable sexual experiences. And almost half of the people had had a physical assault sometime during their life. The rate of traumas that we all experience is really quite high. And it's, of course, much higher in those people who end up having PTSD. Next slide, please. So what happens, with PTSD is that there is a memory that it occurs for a trauma. And when the memory is being formed, it's going to have a high level of emotion associated with it. So that, in this situation, that the phone, and this carries over. I'm sorry, this carries over to other circumstances. So in this case, a parent hears the phone ring. Their immediate thought is, my child might die. The heart is pounding, they're developing fear, and because they have a child with a problem, so that they know that's what they expect, and that's
Do you want
what
me
happens.
to speak to this
Yeah,
slide,
please.
Pat? Okay, so this is me. This is not Morgan. This is Donna, and so it's what happened in our family. So the past accident that this slide refers to is that when I was a teenager, I think I was like 16 maybe. I was alone at home with my father, who had had 3 strokes and had lost his mobility and his speech. And he was sitting in the living room, and I was in my bedroom down the hall. And I heard a noise that didn't sound normal. And so I came out of my bedroom and I ran down the hall and I saw my father. And he was shaking and his head was to one side and his eyes were rolled back. And I thought that he was having another stroke and that he was dying. I thought that I was witnessing the death of my father. And I can't actually remember what happened after that. I think I called 911, and it subsequently learned that my father had had a seizure, that it wasn't a stroke, and that seizures are quite common in stroke patients. And so fast forward to 1990. Nicholas was 2 years old, our son Nicholas, who has cerebral palsy and is medically complex. And it was his very, very first day of a special needs preschool. And this day he had gone off on a bus, and I was sitting in my kitchen table, reading the newspaper, having coffee, for the first moment of respite in his life, because he as a baby, with a neurological injury, he was very, very challenging to look after, hard to soothe, never slept, hard to feed. So he needed very constant attention. And this was the first day that someone else was looking after him. So about a couple of hours after he had left our house on the little bus, the phone rang, and it was the director of the school saying, Nicholas has had a seizure. And this was the very first time that he had had a seizure. And she said, he's in an ambulance on his way to the CHIO, our children's hospital, and he is unresponsive. So I got in the car thinking that Nicholas would die or that he would be fundamentally changed, not the baby that I knew, that he would have more brain injury. And I got to the hospital and the sliding doors opened and I could hear him crying, and I thought, he's fine. I can tell by the cry he's fine. And they said to me, we don't know if Nicholas will have another seizure in the next 5 minutes, if he has epilepsy, or if this will never happen again. We don't know, but it is normal for people with disabilities to have seizures. And, these two events kind of got mixed up in my mind. And so that subsequently, after that happened with Nicholas, every time the phone rang, I had a huge panic attack. Like, I thought something awful was happening because the phone rang. And it took me a long time to get over the fact that it was fine. The phone ringing did not mean an imminent disaster of some kind. And, I had that reaction, even if I was holding Nicholas. Like, it didn't matter that he was not in the house. Like, he could have been in my arms and I would have had the same reaction. Anyway, that's what the story that this slide tells.
Yes. And so what happens, you see, is that these memories are associated with a high level of emotion, and they get coded in the brain actually in a different way, in different places than the normal unhappy memories. And then, of course, with PTSD, they come back to haunt us. So then anything, just a telephone ringing, even if you have the child in your arms, you still get the same type of reaction. You get the fear response because the web of fear has grown and begins to infiltrate different areas of your life. And so that's what happens with PTSD. You start off with a very emotional fear situation, and then it begins to generalize, and other situations trigger it. And then it may cause interference in terms of flashbacks, or it may be bad dreams, or it may be just a very uncomfortable negative feeling that may be more of a depression or anxiety, and it begins to spread through one's life. So it's not unusual with people with PTSD to have an initial types of events, and then it spreads to other potential triggers that then begin to trigger it. And the most natural thing to do, the normal thing to do in that circumstance, is try and get rid of that thought as quickly as possible, just to shut it down, shut it out, get rid of it, throw it away, and not think about it. And of course, when you do that, you feel a little bit better. But unfortunately, what it does is it enhances it continues to enhance the feelings of fear and anxiety. So maybe we should go on to the next slide. So what we see in this little cartoon is that we see that you may have a whole lifetime trauma, parenting trauma, and other stressful events, and then you get a small trigger and you just fall apart. And that's not unusual, that people who say that, that they're carrying a lot of trauma in their history, when they come up against some event that isn't that serious, that may be the trigger that causes them to get more depressed, more anxious, more afraid, more symptoms of PTSD. So they may be carrying everything and doing okay for a period of time, and then another event occurs that may not be the most serious event, that triggers in the PTSD.
Mhm. You know, this was such a big learning moment for me in this study. Um, Never having thought about my own trauma really, well, I thought about it, of course, but I didn't understand the nature of traumatic events and the way they work in this building block effect. And I think that this in itself, for family caregivers to understand that you don't get better at dealing with trauma with practice, you know,
Yeah.
because we tell ourselves, I mean, sure, we all tell ourselves that this is what we should do. We should be so much better now that, you know, this is the third time that, you know, my loved one, my child, my husband, my mother has had a health emergency. I should be able to manage it, you know, myself emotionally much, much better with practice. But it's not like that. Like, you know, I remember saying in the midst of like a lot of traumatic events in Nicholas's life, when he was a teenager, he was very, very, very ill, and I remember the doctor saying to me, you know, what do you need? And I said, I need everyone to be very, very nice to me. And I think I was trying to express that I was that person being on my knees. I couldn't take anybody teasing me. I couldn't take any tiny normal thing that, I mean, I'm a pretty strong person. And um, I think I was trying to express that uh, I needed people to protect me from any small trauma at all,
Right.
to be
And
aware that, you know, and, and, and I remember feeling embarrassed by that at the time. But now that I understand myself, I feel so much self-compassion. And I hope that people listening to this and learning about this building block effect will feel self-compassion and self-understanding, that it's okay, it's normal to be knocked down to your knees after trauma, and that we do need people to be very, very nice to us, and we need to be nice to ourselves.
absolutely, and self-compassion is so important in learning to deal with these sorts of difficulties and traumas. So what happens is that not just another trauma, but just another stressor, you know, a normal little
Mhm.
stressor can trigger, or even a memory associated with the trauma that might have two or three, like the telephone call, like if you were in a traffic accident, the color, you walk by the car with the same color, or you hear something, a car backfire, and you've been in Afghanistan, and that
Mhm.
brings it all back. So I mean, there's so many different ways that then trigger these responses, and that's what PTSD is about. So it begins to dominate one's life. Now, in our experience, what we see is that parents spend an awful lot of time trying to pretend in some ways that they're okay, because their
Mhm.
focus is not to take care of their own life, but their focus and their own health, but their focus is to take care of the loved one. And that's true with all forms of caregiving. Next slide, please. So individuals with PTSD, they've never left the traumatic scene, you know, not because of any weakness or any defect in themselves, but they're stuck in the event. The threat isn't over. Their body, their brain is reacting as if they're constantly under threat, and they're constantly in a survival mode. That the traumatic event is a constant reality, and the present often doesn't feel real because it's just waiting for another reminder of the trauma.
Mhm. I remember, Pat, you saying, uh, you know, when we were talking to some of the parents on the study in the parent advisory group, I remember you saying, um, PTSD is really a problem of memory. And
Right.
I think that's an important distinction, because sometimes we think when we are experiencing ongoing trauma, we may not have PTSD, right?
And well, what happens is, I think very often, I like the thinking of it as memory, because what it does is it makes it clear that the psychological and mental health problems are really because the memory has gone out of control. The memory for traumatic events becomes situated in a different way in the brain and comes back to revisit us and triggers all sorts of irritability, maybe anger problems, maybe fear, and bad dreams. These are, yes, they're mental health problems, and they certainly express themselves as mental health problems, but they really are memory at the core of it. They're because of the way that the memory is stored. And it's not abnormal the way the memory is stored, it's just unfortunate.
Mm-hmm.
So people with PTSD, we do know some things. They're more likely for women to get PTSD than men. And there are some genetic evidence for genetic causes of PTSD, but they're not very simple at all. They're really quite complex, and different populations of people will have different genetic correlates of PTSD. So it's not at all simple. There's no PTSD gene. There's patterns in different populations, and it really has not been well worked out yet. So we can't do a genetic test for people who are susceptible to PTSD. Many people think that it's not a matter of who would get PTSD. It's just a matter of that if you have enough trauma, that perhaps everyone will get PTSD. If there's enough trauma, everyone will. Now, some people develop it with fewer traumas than others, but it's not an abnormal, or people aren't crazy because they have PTSD. Their memory is wrong. Their memory for these traumatic events is interfering with their functioning.
Mm.
Next slide. Okay, so did you were going to say something, Donna?
Well, I was going to ask you, I'm not sure, I questioned myself because I wasn't sure if that's another slide coming up, but I was going to ask you if you were surprised by the prevalence or the incidence of PTSD in the study. Was it higher than you thought it was going to be?
Well, actually, by the time the data came out, by the time we were doing this survey and recognizing it, I wasn't surprised. But prior to that, I was very surprised. I thought that there really would not be much trauma, and you opened my eyes to that. And even after that, it took me some time to really understand that there are so many events that occur in children's lives. Well, even, my own daughter, who's now 39, she had seizures when she was a child. And I was fortunate that I didn't develop PTSD, nor did my wife. But we we thought she was going to be dead several times. I remember once in Banff, and we couldn't get to the hospital, and one thing after another. And all of these events, they take a toll. But I was surprised with the about half of the parents in our survey developed symptoms of PTSD. So they developed the symptoms that would label them as PTSD if they were seen by a diagnostic in a diagnosis.
Wow.
That's
high.
it's not an uncommon phenomena. Now, there may have been a little bit of selection. We didn't recruit people for the survey on the basis of them having a PTSD. We recruited them on the basis of having a child with a neurodevelopmental problem. So I think that PTSD is an unrecognized trauma, unrecognized result of trauma in many of these types of situations for caregivers. There's good data for some caregivers, but not so much for the entire population. So, for example, people who are caring for a child with childhood cancer is a high rate of PTSD. But I think it's an unrecognized problem. People just think that they're exhausted or that they're stressed, and indeed they may be having these flashbacks, these bad dreams, the sense of doom, the jitteriness that often comes because you're always expecting a trauma, always expecting something to go wrong. Anger is sometimes, as I mentioned, a result, and other types of difficulties like that. And we did, as I said, a large survey with about 600 people, and those papers are now beginning to come out. And most of them, we had some fantastic people working. Elisa Kaltenbach, who we imported from Germany as a postdoc, who had worked with the originators of the form of PTSD treatment that we used. Then Ting Zhang, and Ting was a student who came from China for a brief MITAX, which is a federal government agency. She came on a scholarship from them for a few weeks and just tore the place apart in terms of getting things done. Yeah. And she's still working for me. And so that was the survey was her master's thesis. So what we did was if you look at the literature for PTSD, there are many treatments that work, which is a very comforting thing. There's some treatments that work fairly well, and then some treatments that work very well. Now, none of them is guaranteed to work for everybody, but the treatments that work, that are effective, but not as effective as the best treatments, are things like the SSRIs, the antidepressant medication, or dealing with the trauma results. So you might have therapy that focuses on depression, or focuses on anxiety, or focuses on bad dreams. Those are treatments that are helpful. They're very helpful. And sometimes, especially for people that can't have access to psychological treatments, they're the best treatments that are available, but they're not the best treatments. The best treatments are what we call the exposure treatments. And exposure treatments means that you go back and you rejig the memory in the brain. There's several different ways of doing that, but all of them involve changing the memories itself, not dealing with the symptoms, but changing the memories. And the one that we used was called narrative exposure therapy, and we conducted it on ENET, we called it ENET, and we conducted it all by distance. So it was all done virtually, no face-to-face interaction at all. And the other very novel thing is that we used not psychologists, but we used coaches that we trained and supervised very carefully. But these were people with no professional expertise in the area, but they got a lot of expertise after the training and after the experience. So we used ENET, which is narrative exposure therapy. There's several others that I will just mention. There's prolonged exposure therapy, which is probably the best known type of exposure therapy, was developed and has used more for veterans in the United States. That's where it was developed. And but it's also been used in a wide variety of different types of formats. And then there's another type of exposure therapy called, called written exposure therapy, which is the newest one. And it involves writing down what the initial trauma was. And then there's the NET, which is the narrative exposure therapy. And again, you tell the story. With the narrative exposure therapy, you go through all of the different traumas, or many of them. Sometimes there's too many to go through all of them. With the prolonged exposure therapy, we just choose one. And we call that the index trauma. And we focus on it, and we go over the same one again and again. And that's also true of the written exposure therapy. And it doesn't seem to matter. There's been very few head-to-head comparisons, but there's been very few comparisons of one versus the other form of exposure therapy. But the evidence is that there's no difference in their outcomes. They're as effective as each other. So it's not that important that we do all of the traumas in terms of re-exposing and thinking about them. Now, the challenge is that these exposure therapies are a bit tough on the clients and they're tough on the therapists. And so in some ways, the newest one on the block, which is called written exposure therapy, seems to be gentler on both the clients and gentler on the therapists, because one of the things you have to worry about is that you don't want to get a secondary PTSD from the therapist dealing so much with trauma. As one of the therapists said, every day I invite people to come and tell me about their worst possible days. And then I do it again and again and again and again with other clients. But I think that the exposure therapies, unfortunately, are not very well available across Canada. So we did know that we haven't finished the analysis, partly because we're a member of a large group and we're using the analysis group at the University of Alberta, and we're in a queue to get our data analyzed. But we do know that ENAT is feasible with parents, and that paraprofessionals, our coaches, were well accepted and they provided very high quality intervention. And that online sessions are very much possible to do with, there are a little bit more difficulties in some areas, but in some areas they're a lot easier than that. It's a lot easier if you're living in a remote area to actually get to an ENAT rather than a in-person.
And Pat, can you remind us how many appointments with the coach were in this program and how long was each appointment?
Yeah, there were 90-minute appointments with the narrative exposure therapy, and they were about 10. It varied a little bit, but there were about 9 or 10. Now, one of the advantages of written exposure therapy is that it takes fewer appointments, about 6 or 7, and there's 60-minute appointments or 50-minute appointments. But the thing that we found was that the parents, and we also at the same time did a clinical series with firefighters because they're also got a lot of trauma. And we had very positive feedback. So we don't know the exact results of the study, but we do know that it can be done by distance. And this has been found in other studies. And in fact, we did what we call a systematic review. And we found that it appears that distance interventions are as effective as face-to-face. And also in this study and in another study that we did, which was a summary of studies, which Ting, our student, is the first author on, that it's possible to do these interventions with paraprofessionals, not necessarily only with professionals. Now, I have nothing against psychologists. I'm a psychologist and have been training psychologists for years. But the problem is there just aren't enough of us. There aren't enough of us. And if we want to really help all the people that are in need of help, we've got to look at all the alternatives possible.
Yeah.
So we did have some challenges, we did have some challenges that sometimes our kids got into hospital and their parents were in hospital for a long time with their kids, taking care of their kids in the hospitals. There were some new traumatic events and loss of loved ones during the intervention. And of course, COVID interfered with everything in terms of if you have 3 kids and they're being homeschooled, as well as trying to find the possibility for the privacy and the time for a therapy session, that sometimes delayed it. So those were some of the problems that we found.
And, you know, I personally know caregivers who I thought, gosh, they would have really benefited from um, this kind of, um, help. And like I know people who walk into the hospital or even just get into the parking lot and they throw up. I mean,
Mhm.
you know, and and I reached out to those people and I said, why don't you apply for this um, study? Because I know you and I think you would really benefit from it. And they said they were just too afraid. They
Right.
just did not. And they have to go on caring, right? It's not as though you can put your life on hold in order um, to do this. And they were just that if I revisit, if I do these 90-minute sessions, remembering the worst time or the worst times, that I could just, I envision myself falling apart. I
That's
won't be
right.
able to look after my
Right.
child. And I could say the same thing about Alzheimer's caregivers or cancer caregivers or ALS caregivers that I know. What can we say to people who are so afraid?
Well, I mean, I have a very small practice that I have, and I see a lot of people with PTSD, and that's very often the issue. They're very afraid of falling apart, of decompensating if they start the treatment. But in fact, what we find time and time again is that even after, not for everybody, but even after the first session, what we find is that there's some relief. There's beginning to be more relief. And what we find is that there are virtually no, and I've never had an adverse event, a situation where somebody fell apart with PTSD. It's a, and some therapists share in this view. He said, well, how can you subject people who are barely coping to this exposure therapy? And I said, well, look at the data. Look at the data from dozens and dozens of studies. What we find is virtually no adverse events. I haven't seen any adverse events, and indeed, people don't fall apart. These are tough people, and when given the opportunity, and it's hard to get there for some people, but when given the opportunity, they thrive when they get exposure treatment. Right from the first session, it's easier to do. And oftentimes we see that the anxiety is beginning to get lessened and lessened and lessened. Now, everybody's different, and some people it may be not till the fourth or fifth session. Some people, unfortunately, and we don't know why some people don't get relief from this, but most do. It's one of the most effective exposure therapies are one of the most effective treatments for PTSD.
Mm.
So
Well,
it's a
that is
good news
such
story.
a
They feel better
hopeful,
right away.
yes, it's such a hopeful message. Um, I know we only have a few minutes left, but Pat, can you just briefly um, keep, we're just going to keep the hope going strong here and talk about some of the plans to bring this to people who need it in Canada and maybe even
Okay, so
beyond.
we are now negotiating with an organization that provides care by distance using to try and see how we can get this implemented and trying to get the funding to see how we can get it implemented into for regular care, not just a study. And certainly there are some psychologists who will do exposure therapy. And these are many different types, and they all seem to be equally effective. And so that I would encourage anybody who is a caregiver who has the symptoms of PTSD to talk to their family doctor and then talk to maybe what they need is, maybe it'll be sufficient to use antidepressant medication, the SSRIs, because they do help some people quite well. But if those don't help, then maybe the thing to do is to go and see a psychologist and really do their best to get into some exposure therapy situation. So we're hoping to make this available It will take some time. Funding is always an issue, but we're working with agencies and moving this forward. I really appreciate the chance to talk today with you, Donna. It's always fun to talk with you. And I hope that people will consider the fact that maybe PTSD is something that we don't have to live with, that we can actually do something about.
Yeah, that's a wonderful, wonderful message to end with. And of course, you know, as these plans move forward, and if we are able, you know, Pat, if you are able to move this ENET therapeutic intervention into the public domain where people can access it, it will be free. That's the aspiration, and we will, you know, shout it from the rooftops and announce it here at Caregiving Essentials newsletters, the course website, everywhere that we possibly can, if we're able to offer this generally to the public of caregivers, all caregivers who need it. Thank you, Pat, so much.
Thank you
It's
very
been
much.
a wonderful pleasure to speak with you. And I will hand it back over to Erin for some announcements.
Thank you, Donna, and thank you, Dr. McGraw, for that very honest and just honestly wonderful discussion that you had. And thank you for the participants that joined us for today. And that will be it for us today. Thank you all so much for coming, and have a wonderful day.